All right, very good evening to everyone. Good evening. So we are going to do the leftover part from contraception. So this is not going to be a very long class. It's going to be a short and crisp one. So we would be covering the combined estrogen and progesterone forms of contraception, right? And so I'm going to start with combined oral contraceptive pills. Okay, that's what we are going to start with. Now, as far as your exams are concerned, I don't think any exams are going to happen in the first week of May. I think all of them are going to get postponed. The situation is really very, very tough. For the hospitals and for the consultants, and I don't think there are people available or willing to take the exams as well. So you guys would have to continue with your residency as of now, but let's wait for individual notices in your respective colleges. Okay, and then let's see where we land into, right? Okay, so now, when we talk about combined oral contraceptive pills, we are no longer using any form of high dose pills, right? So what we are using are low dose pills. Now, please remember, as far as the classification goes, one classification is low dose, high dose, or very low dose pills. And then there is another classification which is based on generation, right? So first generation, second generation, and so on. Now, when we talk about low dose, okay, so low dose or high dose or very low dose, this is based on the estrogen component, right? So this classification is based on the estrogen component of the combined pill, right? And majority of times the formulation of estrogen that is there in these combined pills is going to be ethinyl estradiol, right? Now, when we talk about generation of pills, right? So when we say first generation, second generation, and so on, right? What do we mean? So when we talk about generations, we are actually talking about the progesterone component. Yes? So this is based on the progesterone component of the pills. Right? Now, the first generation is actually norethindrone. Right? So that's the first generation progesterone. So although it is primarily a progesterone, it will have some estrogenic action as well, and it has androgenic action as well. Right? So when you talk about second generation, this is LNG. Okay? So this is levonorgestrel. Right? So second generation is LNG or levonorgestrel. Right? When you talk about third generation, these are what are currently most commonly used in the OC pills. So currently these are the most commonly used in the OC pills. They are desogestrel, gestodine, and norgestimate. Right? And then when we say fourth generation, this is spironolactone derivatives, right? So spironolactone or even Dynogest, right? So these are all a fourth generation. Now what you have to remember here is that when you say, first generation, second or third, what you have to know is as the generation increases from first to second to third to fourth, what is going to happen is androgenic side effects keep decreasing. So as generation increases, the androgenic side effects will go on decreasing. And you have to know that actually the fourth generation progesterons are going to be anti-androgens. Right? So the fourth generation are actually anti-androgens. Right? Now, once we know what is the classification of low dose and generation, right? Now, as I said, currently we are using only low dose pills. So what exactly do you mean when we say low dose? So when we say low dose, it means they are going to have less than 50 micrograms, right? So they're going to have less than 50 micrograms. Now, these days we are actually starting with 20 micrograms. So currently we are starting with 20 micrograms of ethinyl estradiol. इससे पहले आपने पढ़ा होगा that most women were taking 35 micrograms. So सबसे पहले it was less than 50, but most of the pills had 35 micrograms. These days, then when we start oral contraceptive pills for our patients, we will start with the 20 microgram dosage. Yes, so these are the possible options. What is the lowest possible dose? Anybody? What is the lowest possible dose of ethinyl estradiol? So lowest possible dose of ethinyl estradiol is actually 10 micrograms, and that is FDA approved, right? So the lowest possible dose is 10 micrograms and it is FDA approved. So this is a form of contraception which will have both the hormones, estrogen as well as progesterones. Now, once we know what are they made up of, let's talk about their mechanism of action. Yes, this is very important. So if I ask you what is the main mechanism of action, can you tell me what would be the answer? What is the main mechanism of action? So when you say main, their main action is suppression of ovulation, right? So suppression of ovulation. And how do they suppress ovulation? By doing inhibition of what? So they do a negative feedback, right? So they will do inhibition of GnRH as well as LH as well as FSH, right? Now please remember, there is no doubt that there is inhibition of GnRH and LH and FSH. But out of these, the most important is inhibition of FSH by the estrogen, right? So most important is inhibition of FSH. So क्या होता है? If there is inhibition of FSH, there is no follicular development, right? And if there is no follicular development, there will be no dominant follicle, है ना? So there will be no dominant follicle. And उसके ऊपर से to add on, there is no LH surge as well, so there is no ovulation, right? Now, this is actually the main mechanism of action. But you know, because they are hormones, they will have effect at other levels as well, right? So I'm going to write them as additional mechanism of action. Okay, so if we talk about the additional mechanism of action, naturally they will have effect on the endometrium. So please understand that these pills have very low amounts of estrogen. So if you keep giving it for a long time, can you tell me what effect will it have on the endometrium? They will eventually cause thinning of the endometrium or atrophy, right? So they will eventually cause thinning of the endometrium, and that is why we say one of the additional methods of action is inhibition of implantation. Right, so one additional mechanism is going to be inhibition of implantation. Please remember this very importantly. Since they are causing thinning of the endometrium, यही बात मैं दोबारा आगे reinforce करूंगी when we talk of their non-contraceptive benefits. So remember this, that this is one of the mechanism of OCTs, that they will cause thinning of the endometrium. So they will actually reduce the blood loss in the menstrual cycle as well. Okay, we will talk about it again. Then another important additional mechanism of action is its effect on the cervical mucus, right? So if you talk about effect of the cervical mucus, you know that progesterone is going to make the mucus thick. right? So it is going to make the mucus thick, and therefore sperms will not be able to penetrate it that easily. And then yet an additional mechanism of action is impaired tubal motility, right? So impaired tubal motility and peristalsis, right? So these are all the mechanisms of actions of combined oral contraceptive pills. Now, सबसे पहली बात है, whenever you want to give a hormonal contraception to your patient, you have to see whether she has any absolute contraindications or not. So the other day I did talk about absolute contraindications, okay, of other hormonal contraceptive methods, and I said whenever we say absolute, we mean WHO category 4, right? So we mean WHO category 4 और इसमें नहीं देना है, right? So let's see if you know some of the contraindications. Can you enumerate some contraindications for me? For example, the one I will start with is age. So please remember, age itself is not a contraindication. But if your patient is more than 35 years of age and she is a smoker, so age and smoking combined is going to be a important absolute contraindication. And if we go into very many details, they say smoking more than or equal to 15 per day, right? So age and smoking together is an absolute contraindication. Second, if your patient has multiple risk factors for cardiovascular disease, right? So if she has multiple risk factors for cardiovascular disease, for example, age bhi zyada hai, patient is a smoker as well, she has diabetes, she has hypertension. So, you know, these are together important risk factors for cardiovascular disease, right? So if multiple risk factors are present, then it is again a absolute contraindication. Okay. Purnima is absolutely right. So I'm going to talk about it. This is important. So when you talk about diabetes, you have to know that diabetes alone again is not a contraindication. But yes, diabetes with vasculopathy, you are right, is going to be a contraindication. Then I want to correct, Purnima has written uncontrolled hypertension. So no, actually जब आप WHO criteria देखते हो, WHO कहता है if the blood pressure is more than or equal to 160 by 100 millimeters of mercury, then it is an absolute contraindication. जबकि CDC कहता है, which is what they follow in the US, then even if the blood pressure is more than or equal to 140 by 90, these women should not be prescribed oral contraceptive pills, right? Priyanka, because increasing age with these risk factors increases the risk of cardiovascular events, right? So age alone is never a risk factor, but age with other risk factors is going to increase the risk of cardiovascular events, okay? Then very, very important is venous thromboembolism. So women who are high risk for venous thromboembolism are important contraindications for OCPs. So if they have a prior history of venous thromboembolism or stroke, right, they are going to be absolute contraindications. Then ischemic heart disease. So if your patient is already a known case of ischemic heart disease, or we say coronary artery disease, right, then again it is going to be a absolute contraindication. Now what about breast cancer? So please remember, current or past, right, history of breast cancer, right, is going to be a absolute contraindication. So whether it is a current thing or a past history, it is going to be a absolute contraindication. Then any other that you can tell me? So again, very important is migraine. Please remember, not every migraine is a contraindication. So migraine with aura, ठीक है, जिसको पहले क्या कहते थे, migraine with focal neurological deficits, right? So pehle we used to put it like focal neurological deficit, okay? So please do not confuse this with menstrual migraine. Menstrual migraine is something that women often get because of fluctuation of hormones close to menstruation. And in fact, the treatment of menstrual migraine is OCPs. So you have to be very clear when you write migraine, what is the contraindication is migraine with aura or migraine with focal neurological deficits, right? Then, yes, liver disease is an important contraindication for both estrogen and progesterone, right? So if your patient has cirrhosis, okay, or she has active liver disease, so I'm going to put it as active liver disease, they become absolute contraindications, right? Very good, Rajni. And finally, hepatocellular adenoma. Okay, hepatocellular adenoma, right? So these are important contraindications. Also, please remember unexplained abnormal bleeding. So whenever you have a patient who has unexplained abnormal uterine bleeding, you have to first find out the cause, right? Then you may or may not give OCPs. But when you write unexplained bleeding, before you give any kind of hormones to your patients, you must evaluate the patient. Same holds true for a known or a suspected pregnancy. If your patient is already a case where you are suspecting that she could be pregnant, right, again we will not give her either estrogen or progesterone contraceptives, right? So known or suspected pregnancy, and then as I said, unexplained abnormal uterine bleeding again should be taken as contraindications. Okay, is this clear to everyone? Now, are OCPs an effective method? So yes, they are a very effective method of contraception. So if you talk about perfect use failure rate, right, then this is 0.3, right? Whereas if you talk about typical use, then this is around 7%. Okay, some textbooks go up to 9% as well, right? So perfect use is 0.3 and typical use is 7%, right? Now, what is the regime of these pills? Do you know in what regime do you give these pills? Anyone? Because these are common things. So no matter what OCP your patient is using, the regime is something that we have to know. Contraindications is something that it will apply to all types of OCPs irrespective of what component they have, right? So what is the regime? No, endometrial cancer is no contraindication, okay? Now what is the regime? So when we talk about the regime, I am sure you all know a 21/7 regime. Do you understand what that means? So here by 21 we mean these will be 21 hormonally active pills, which means these 21 pills are going to have the hormones. And what is the meaning of this 7? The 7 are non-hormonal pills, right? So these 7 are non-hormonal pills, right? Now, since we are reducing the dose of estrogen more and more, so पहले 50 आया, 50 से 35 micrograms आया, अब 35 से हम बोल रहे हम 20 micrograms देंगे. Do you know what is the newer regime? So what is the newer regime? The newer regime to give OC pills is 24/4, right? What does this mean? This again means the same thing. 24 will be active hormone pills and 4 will be non-hormonal pills or placebo. What do you think is the advantage of doing this? So because you are increasing the overall coverage of the hormone in the cycle, this regime will have better efficacy. Okay, so this regime will have better efficacy because the coverage of the hormone is becoming more in the cycle, right? The second important thing is because the coverage is increasing, like there will be less side effects like withdrawal bleeding, right? So menstrual migraine, these are going to be less. So better efficacy and less side effects like menstrual migraine, okay, like withdrawal bleeding, right? So why? Because I told you what is the reason for menstrual migraine. The reason for menstrual migraine is hormone fluctuations which are extreme close to a menstrual cycle on menses. So when you increase the coverage, these fluctuations are less and the episodes of menstrual migraine are also going to be less, right? So this is the newer regime. So you should know, if somebody asks you what is the new format of giving the drugs, it is 24/4, right, which can be given because we are reducing the dose of estrogen now to 20. As I said, we start with 20 micrograms. Okay? Then, whenever we are thinking of giving a hormonal contraception to our patient, and when you are counseling the patient, also for you to understand which method is good for your patient, you have to know what are the advantages of a method, or in other words, what are the non-contraceptive benefits of the method, right? So when you counsel the patient, telling them these non-contraceptive benefits or telling them the advantages will always help in patient selection of the method, right? So I'm going to write it as advantages, or I'm going to write it as non-contraceptive benefits. So either ways you can put it, right? So the first thing is, what about, is there any delay in return of fertility? So if your patient is going to ask you this, is there any delay in the return of fertility? What would you say? The answer is no. So please remember that they are rapidly or rapid reversibility is what you see with combined oral contraceptive pills. I will talk about reversibility again, but most women will have return of fertility by 1 month. Okay. Then what is the other advantage? As I said, you are giving them in a particular regime, good way of regularizing the menstrual cycle. They will have scheduled bleeding with this method. Okay. The third advantage, as I said, because thinning of the endometrium, they will reduce menstrual blood loss. Right? So, women where the menstrual blood loss is more, you could definitely use OC pills. A typical example being fibroid uterus. Right? So, to reduce the bleeding, you could use OCPs. Right? Then, they also lead to improvement in dysmenorrhea because they make these cycles anovulatory, right? So please remember that the cycles with OC pills are anovulatory. Very, very important, okay, is that oral contraceptive pills are going to be decreasing risk of 2 malignancies. Do you know which one? So they decrease the risk of ovarian as well as endometrial cancer, right? So you, I hope you remember that we did talk about OCPs being one of the forms of prophylaxis in women who have, high risks. Also, when you talk about endometrial hyperplasia, as long as it is simple hyperplasia and without atypia, one of the treatment itself is combined oral contraceptive pills, right? Then, any of the pelvic pain disorders, for example, endometriosis, right? So you could use these in pelvic pain disorders. Yes, is it okay? Then, not only are OC pills going to protect from ovarian cancer, you have to know they are protective in the development of what? Ovarian cysts, right? So they are protective for the development of ovarian cyst. In fact, ये एक चीज याद रखनी चाहिए आपको. When you talk about OCPs and you talk about progesterone only methods, OCPs actually reduce the risk of ovarian cysts. But when you talk about progesterone only methods, they actually increase the risk of formation of ovarian cysts, right? So OCPs decrease and only progesterone compounds are going to increase the risk, right? Then one of the other non-contraceptive benefits is its use in hyperandrogenism. Right, so it's used in hyperandrogenism. In fact, they are the drug of choice for hirsutism as well, right? So that's because they are going to do what? How do they help? So number one, they decrease the GnRH secretion. Can you tell me by what other method do they help in hyperandrogenism? By what other method do they help? So please remember that जहाँ पे भी estrogen होता है, it increases the binding globulins. Yes, so estrogen increases the sex hormone binding globulin. So testosterone binding forms are increased and free forms are decreased. The third mechanism is that these pills decrease the adrenal androgen production, right? So they also decrease the adrenal androgen production. Bache, Sana, I said when you are giving these pills and you give them for a significant amount of time, what is the effect on the endometrium? It is endometrial thinning, right? Eventually they can actually cause endometrial atrophy itself. That's why you're using it in hyperplasia. So whenever there is a risk factor for endometrial cancer or endometrial hyperplasia, OCPs are important. We talked about this when we talked about endometrial cancer as well. Okay? So the mechanism is by causing thinning or stopping the proliferation of the endometrium, right? Then what else is the non-contraceptive use? Let me see if you can tell me any other non-contraceptive use. So another important non-contraceptive use is primary hypogonadism, right? So when the ovaries are non-functioning, right, you could supplement the woman with the exogenous hormones. So if the ovaries are not making sufficient ENP, you could give the estrogen and progesterone from outside, right? Premature ovarian failure, where again you need to replace the woman with the hormone. So you're going to give them E+P, and one of the methods to give it is combined oral contraceptive pills, right? So these are some of the non-contraceptive uses, or I would say advantages. Another advantage that I want you to know is that they improve bone density. Do you know that? So because of the presence of estrogen, OCPs are going to improve bone density. Not hypoandrogenism, beta, hypogonadism, right? So if it is a non-functioning ovary, okay, they are used in the management of hyperandrogenism hai, PER hai, okay, this is ER, hyperandrogenism, like, so I said they are the drug of choice for hirsutism as well, okay. Now, once you know this, which is advantages, let's go on to the risks as well, right? क्योंकि ये चीजें are going to be common to all OCPs, yes, so irrespective of the brand name, irrespective of the exact progesterone being used, the regime that you will give them in, the advantages and the risks are common, right? So once you know this, we should also know the other extreme, right, which is risks and side effects. Okay, now the first thing I want to say here is that there are certain side effects which are more when the woman initiates it. मतलब शुरू में ये वाले side effects होंगे, but उसके बाद ये side effects कम होते जाएंगे, right? Yes, Daljit, you can always keep increasing the dose. It doesn't matter, right? So OCPs basically means there is going to be an estrogen component and there is going to be a progesterone component. Depending on the indication for which you are going to give, you can increase or decrease the dose of estrogen component. So if somebody is having more of breakthrough bleeding with 20, you can give them a 30 or 35 microgram ethinyl estradiol, right? So it depends on how well the woman tolerates, but you should actually start with the lowest dose or low doses, which is like 20 micrograms, because the side effects will be less, okay? Now, when we talk about the risks and side effects, so the initial side effects, which are like nausea, okay, bloating, breast tenderness, right? These are initial side effects, and these side effects will resolve soon. So they are not something that will persistently be present. They are when the woman begins the pills for the first time, and these will resolve soon. Okay? But the other side effects that we are going to talk about, they stay there with the OCPs. For example, venous thromboembolism. Now this is something that you should definitely know, right? All OCPs, right? All OCPs are going to increase the risk, right? Because they are procoagulants. So therefore, if your patient has multiple risk factors, or if she has previous history, they are contraindicated, right? उसमें कोई सवाल ही नहीं पैदा होता कि can I give very low dose or can I give low dose? No. So when you talk about venous thromboembolism, right, all forms of OCPs are going to be contraindicated. But here still, just to help you understand, when you talk about third or fourth generation OCPs, okay, just a moment. Right. So all OCPs are going to increase the risk of venous thromboembolism. So I said whether it is low dose or it is 20 microgram or it is 30 microgram or it is whatever progesterone, all OCPs are contraindicated. But here something which they have to understand, which you have to understand is when you compare third generation progesterones with fourth generation, right, progesterones, which of these have a higher risk of venous thromboembolism? So please remember the risk of venous thromboembolism, okay, is going to be more with third generation progesterones as compared to with fourth generation progesterones, okay. हाँ, सो पूनम उसमें क्या मुश्किल है बता पाना? सो ये तो बेसिक्स है ना बेटा हार्मोन के. सो व्हेन वी से दैट देयर इज venous thromboembolism, you have to know that it is primarily because of the estrogenic component, but it could also be because of the progestational component. The progesterone also adds to it, right? So when I talk about it, you will understand more and more as we go to each component, okay? Then the second important risk is cardiovascular risk, right? So cardiovascular risk, for example, as I said, hypertension, MI, stroke, right? In सबके risk increase होते हैं. So again, if I ask you now, Poonam, you will answer. Okay, if I ask you, these risks are primarily because of which component, E or P? They're because of the E component, भाई ईस्ट्रोजन होता है ना, विच इज मोर ऑफ अ प्रोकोएगुलेंट. यस, सो all these risks, whether you talk about venous thromboembolism or you talk about cardiovascular risk, they are all because of the estrogenic component. And that is why if you see, we are reducing the dose of estrogen more and more, ताकि ये वाले सारे side effects जो हैं वो कम हो जाएं. Yes, Poonam, do you understand? Okay, but having said that, मैंने specially बोला that for VTE, although the primary cause is estrogen, but even progesterone compounds increase the risk. है ना पूनम? Or did you attend the last class where I also taught you that if you talk about implants and if you talk about DMPA, they are also contraindicated when it comes to venous thromboembolism. Remember? Yes. So this is because the third generation progesterones have a higher risk of causing thromboembolism as compared to fourth generation. Okay? Then the third is they can increase the risk of breast cancer. अब मेरी बात बहुत ध्यान से सुनोगे. So when it comes to breast cancer, please remember current OCP use. Okay, it's not past use. किसी ने पहले 5 साल यूज करी तो अब उसका कैंसर का खतरा बढ़ जाएगा, ऐसा नहीं है. Okay, current OCP use may slightly increase the risk of breast cancer. But this is generally not statistically significant and it is short term, which means once the woman stops the OCPs, the risk is going to reduce, and by 5 years it will be as compared to non-users. The same holds true for cervical cancer, right? So please remember that for both breast cancer and cervical cancer, it is the current use which is going to increase the risk slightly. It's not the past use of the patient, right? So currently if somebody is using, then their risk is slightly higher, right? In some of the studies. So it's not universally seen in all studies, but in some studies, in the current users of OCPs, there may be slightly higher risk of breast cancer and cervical cancer, which is not very statistically significant, and it is a, it is a reversible risk, which means once a woman stops using OCPs, the risk will reduce, and by 5 years of discontinuation, the risk is same as that of non-users. Okay. APLA and SLE. Yes, APLA is a condition where there is thrombosis, right? So women who are at high risk, for example, APLA or SLE, yes, for them OCPs should not be used. So concepts remain the same. जहाँ पे भी prothrombotic states हैं, वहाँ पे OCPs are to be avoided. Okay, they are not to be used, right? Then, although, when you talk about the rate of PID overall, the rate of PID is not increased. But if we talk about certain specific infections, can you tell me which infections tend to be higher with OCP users? So chlamydia and candida. Okay, so chlamydia and candida infections are increased, but as I said, please remember the total risk of PID, okay, or rate of PID is not increased. So most of these infections, even if they happen with chlamydia, most of these infections are subclinical infections, right? So the overall rate of PID is not increased in OCP users. Is it clear to everyone? Okay. Now, when we talk about the progesterone and the estrogen components, right? Do you know any other estrogen that can be used in the OC pills? Just for your Viva questions. Any, apart from ethinyl estradiol, any other estrogen that can be used in the OC pills? So just in case they ask you, remember estradiol valerate. So most common is ethinyl estradiol, but estradiol valerate can also be used as the estrogenic component in OCPs. And if you want to compare the two, generally we say 2 milligrams of estradiol is equivalent to of estradiol valerate, okay, is equivalent to 20 micrograms of ethinyl estradiol, right? So if you want to compare the potency, this is how you compare the potency of estradiol valerate along with or with ethinyl estradiol, right? Is it clear? Now, some of you, although in India we are primarily using one pill in one format, there are various ways how you can give OC pills. So if you talk about various dosing schedules, right, then just to explain you what we mean by these terms, right? For example, have you heard monophasic pills and multiphasic pills or biphasic pills? Have you heard of this? So what exactly do we mean when we say monophasic? Now what monophasic means is that throughout the cycle, so for example if it's a 21/7 cycle, so throughout the cycle the 21 hormone pills will have the same amount of hormone, right? So this means they have same dose of the hormones throughout. Okay? So they have the same dose of the hormone throughout the cycle. That's what monophasic means. And this is what we are using most commonly in India, right? So we are using monophasic pills. But in case your examiners ask, do you know what is a multiphasic pill? What is multiphasic? Multiphasic is when the dose of either the estrogen or the progesterone component or maybe both is going to vary in the cycle, right? So during the active phase pill, the dose is going to vary of estrogen or progesterone or maybe both, right? So that is what is the meaning of multiphasic pills, right? I'll tell you why the concept of multiphasic pill was introduced, but first let's write down what it means. So it means the dose of either one or both the hormones, right? So dose of either one or both hormones will vary, okay, during the active pill phase, right? So if it's a 21/7 phase, the 21 are hormonally active, but they will have different levels of hormones, right? Now, why was this introduced? This was actually introduced to reduce the total hormone dose and therefore reduce the side effects, right? So people came out with multiphasic pills to reduce the total hormone dose and thus reduce side effects. Okay. Somebody had previously asked about a doubt on, I think Mr. Obzen Gaini ne pucha tha, why lower dose pills are associated with more unscheduled bleeding. मैं अभी बताऊंगी. Okay, Mr. Obzen Gaini, just give me some time. Let me reach that part and I will explain you why the bleeding is more of a concern with these lower dose pills. Okay, so we'll talk about it in a moment. Then another, I'm sorry. Then another format of giving the pills is cyclic or continuous. Those are the other terms. Cyclic is what I have explained you a little while ago. So 21/7 or 24/4, this is what is cyclical. So 21 or 24 are hormonally active pills and 7 and 4 are placebo pills, right? They are placebo pills, alright? What is the meaning of the word continuous? Can you now tell me what is continuous? Continuous means there will be no non-hormonal pills, right? It would be just hormonally active pills given throughout, right? So continuous means no non-hormonal pills. It is simply a continuous use of hormonal or hormonally active pills. That's what is continuous. Now let me see if somebody can tell me what is extended cycle. Anyone? Can you tell me what is extended cycle? So one is cyclical, one is continuous. दोनों के बीच में आता है extended cycle. वो क्या होता है? So extended cycle ये होता है that instead of the regime being 21/7, the regime will be 84/7. What do you understand by this? The hormonally active pills will be taken for a longer time, approximately 3 months. Yes. So approximately 3 months is, this cycle duration. So out of these 3 months, 84 will be hormonally active pills and 7 will be your non-active or placebo pills. Right? Absolutely right. So Purnima, Poonam and Rishabh. Right? So total cycle length हो जाएगा 90 days, जिसमें से hormonally active 84 days होंगे and 7 days are going to be placebo. Right? Okay. Now, coming to where do you think that these regimes, which are continuous regimes, they will be useful? So, ज़्यादातर when you talk about contraception, we are using the monophasic and we are using cyclical. Yes? Can you tell me indications where you feel continuous regime is going to be useful to your patient? Right? So, where is continuous regime useful in? So देखो concept क्या है? When you want a longer suppression of endogenous hormones, basically what these pills are doing is they are causing a HPO suppression, right? So they are causing ovarian suppression. If they are causing ovarian suppression, the endogenous hormones are reduced. So whatever hormones your patient is getting are the exogenous and they are very small in amounts. ठीक है? So जिस भी condition में आप चाहते हो that the estrogenic exposure should be minimal, there you can actually use continuous regimes. For example, very good. So as Purnima mentioned, in endometriosis, right? So where you want minimal estrogenic exposure, right? So endometriosis. Then very, very important, last 7 days will be placebo sana, okay? Non-hormonal pills, placebo pills, okay? The second place where continuous regimes are useful is PMDD, right? So premenstrual dysphoric disorder, right? So please remember, PMDD is because, what is the reason behind PMDD? It is hormonal fluctuations. So when you give these OC pills, you are blunting the hormonal fluctuations, है ना? कोई hormonal fluctuation नहीं होंगे और इसीलिए patient को ये वाले symptoms नहीं आएंगे. So PMDD is the second area where they are very, very useful when given in a continuous format. The third is hyperandrogenism, where you want a continuous ovarian suppression, right? So hyperandrogenism. Fourth, it may be used in a continuous manner in the management of hot flashes, right? So if you want to manage hot flashes, you again don't want any hormonal fluctuations. You want to blunt the hormonal fluctuations. Yes? Then women who have dysmenorrhea. So if somebody has quite severe dysmenorrhea which they can't really manage and they want to get rid of it, then yes, continuous regimes are useful. And lastly, it may be a lifestyle need of a patient. She may say, doctor, I have a lifestyle where I don't want to bleed every month, right? Because I travel a lot or whatever XYZ reasons, right? So if it's a lifestyle need where she wants, where she does not want cyclical monthly bleeding, we can give them continuous dosing. Yes, is it clear to all of you? Now, once you know these things, let's look at how to start this medication for your patient. Okay. Now, if you have to start this medication for your patient, can you tell me what all do you want to look for, or do you want to ask for? So as far as prescribing OC pills are concerned, one important thing that you have to ask the patient is her medical history. So you have to rule out things like high risk for stroke or venous thromboembolism, risk factors for coronary artery disease, risk factors or diabetes with vasculopathy, or a cigarette smoker. So medical history has to be definitely taken, okay, before you prescribe OCPs. Then second important thing is blood pressure measurement. So before you prescribe OCPs, you don't need any lab tests. You don't need to ask her to get a battery of laboratory tests done, but yes, a BP measurement is mandatory, okay. Third is body weight, okay, because the risk of thromboembolism, right, it actually depends on the body weight of the patient as well. So you should take the weight of the patient. Also, it helps you to keep track of the weight changes that the pill might do. We will talk about it. Okay? So take a detailed medical history of your patient, do the blood pressure measurement, and take the body weight. Now I want to ask you, should you do a pelvic exam? Is it mandatory to do a pelvic exam before you prescribe OCPs? Nikunj, yes, so Nikunj is asking me, heavy menstrual bleeding due to fibroid. You can definitely use OCPs, but we generally don't use it in a continuous manner, right? So जब भी आप उसके लिए use करते हो, आप cyclical use करते हो most of the times, okay? Then Amigo, if we actually go with continuous ka core definition, it means you're giving it for a span of 1 year. Right? So when you say continuous, the core definition or the textbook definition is continuous drug therapy for a span of 1 year. Okay? So it's not just more than 90 days. To meet the definition, it is actually 1 year. Alright? Okay. So what about pelvic exam? So please remember, pelvic exam is not required. Right? So you don't need to do a pelvic examination before you prescribe oral contraceptive pills. Now once you have gone through these things, you're going to ask her to start the drug. What patient को क्या बोलोगे, कब start करना है? So what is the ideal method? Okay, so ideal method to start is day 1. Right? So ideal method to start is day 1 of the menstrual cycle. Right? Why? Because only when you start it on day 1, it has maximum contraceptive effect. Okay, it will have maximum contraceptive effect and no backup method is needed. Right? So no backup method is needed. Okay? But every time it may not be possible to wait for day 1. So ये ideal है, लेकिन हर बार हम ideal चीजें नहीं करते हैं. So classically we say if you want to initiate the drug, okay, we say initiation can be done any time as long as pregnancy is excluded. Right? So actually practically you can start the drugs any time for your patient as long as the pregnancy is excluded. Now इसमें दो तरीके हो सकते हैं. One is a quick start. What do you understand by quick start? Anybody? So quick start means आपने आज उसको prescribe किया, उसने कल से शुरू कर दिया, which means she will start immediately. Right? But with this method उसको क्या करना पड़ेगा? She will have to use, okay, so she will use backup method of contraception, right, for 7 days. So in the first 7 days when she is starting the pill, she needs to use a backup method of contraception. So that is what is quick start. Then there is a Sunday start as well. ताकि पेशेंट्स को याद रहे, राइट? सो देयर इज अ संडे स्टार्ट, राइट? सो इन संडे स्टार्ट वो क्या करती है? शी विल स्टार्ट द ड्रग ऑन द फर्स्ट संडे आफ्टर हर पीरियड्स, right? So she will start the OCPs on the first Sunday after her periods. अब ये first Sunday within first 7 days भी हो सकता है, within first 5 days भी हो सकता है, या after 5 days भी हो सकता है. So if this first Sunday is beyond 5 days of LMP, right? So if the first Sunday turns out to be beyond 5 days of her LMP, she needs to use a backup method. Okay, then she needs to use a backup method for 7 days. Is this clear to everyone? Yes? Okay. Right, so this is how she is going to start taking the pill, and then depending on the regime that you're giving her, 21/7 or 24/4, she has to take the drug. Now comes a very important concept, and that is missed pills. Okay, first I will tell you what is given in the textbooks, and then I will tell you a slight variation which is given by the AOGD. राइट, सो AOGD ने थोड़ा सा वेरिएशन दिया था, मगर मैं आपको पहले किताबी बात बताऊंगी और फिर AOGD के बारे में बताऊंगी. राइट, सो मिस्ड पिल से क्या मतलब है? नाउ इफ द पेशेंट मिसेस 1 pill, okay, so if she misses 1 pill, ऋषभ, क्योंकि अगर पेशेंट को हाई रिस्क है, राइट, तो कोई भी OCP नहीं देनी बेटा, ना तो फर्स्ट जनरेशन, ना सेकेंड, ना थर्ड, ना फोर्थ, right? So if your patient has high risk factors for VTE, no OCP is to be given, right? But because the other side effects are less with third generation pills, they are more commonly used, right? Because the androgenic side effects are less, right? So all those are less, and that is why we are either using third generation pills, and if required, we are using anti-androgens as well, okay? This does not matter, okay? This does not matter because if your patient is high risk, तो कोई भी नहीं देना, ना तो first generation, ना तो fourth generation, ठीक है? Vishakha is asking why only 7 days. So Vishakha, because that is the time the pills take to do a significant feedback inhibition and suppression of ovulation. Yes, is it clear? So a minimum of this time is required to attain sustained blood levels which can do a continuous inhibition of GnRH, LH and FSH, which is what is the mechanism of action of pills, right? Okay, we will talk about that as well, don't worry. So Amigo is asking, a Viva question is, at what age can we start and stop the pill? The answer is, you can comfortably or safely give pills to adolescents, and you can give OC pills right up to menopause. ठीक है? So आपने अभी पूछा इसलिए मैंने जवाब दिया Amigo, but I will talk about it again as well. So please remember, OC pills are safe, absolutely safe for adolescents, as well as they can be given right up to menopause, right? Provided she is not a smoker. ठीक है? क्योंकि अगर स्मोकर है तो हमने कट ऑफ लगाया है 35 years. Okay, Amigo? Right. Now let's move further. So missing the pill. Okay. So if she misses 1 pill, तो क्या कहोगे? So if your patient is missing 1 pill, our advice is take the pill or take the missed pill as soon as she remembers. Okay. So she has to take the missed pill as soon as she remembers, and then she has to continue taking the pill as she was, okay, and continue taking the one pill each day. सिर्फ फर्क क्या होगा? She will finish her cycle 1 day earlier, है ना? So she will finish her cycle 1 day earlier. सिर्फ यही होगा. But if she is missing only one pill, no backup method of contraception is needed. Okay, so no backup method of contraception is needed. Right? Is this clear to everyone? Okay. Then, if she misses more than one pill, so let's put it like if she is missing more than or equal to 2 pills. Okay? So if she is missing more than or equal to 2 pills, एक general guideline है पहली, okay, that she will have to use backup method of contraception. Right? So she will have to use a backup method of contraception. Now coming to specific things. Suppose if she misses, okay, if she misses more than or equal to 2 pills in the first week. अब प्लीज इसको समझना है, रटना नहीं है. फर्स्ट वीक का क्या मतलब है? दिस इज द वीक आफ्टर हार्मोन फ्री पीरियड. समझ रहे हो? सो दिस इज द वीक आफ्टर द हार्मोन फ्री पीरियड. सो अगर उसने 2 पिल मिस किए हैं, right, in the first week itself, तो क्या करना है? What is she going to do? So then what is she going to do? She has to use backup method. And again, if I ask you for how long, the answer is 7 days. क्योंकि 7 continuous pills चाहिए to bring the levels to cause suppression again. So she has to use a backup method. और अगर इस दौरान पे she has also had, so not only has she missed 2 pills, but she also had unprotected intercourse. So एक तो बात हुई कि उसने 2 pills मिस कर दिए. दूसरी हम बात कर रहे हैं pills खाली मिस नहीं कर रहे हैं, there was unprotected intercourse as well, right? Then she will have to use emergency contraceptive. Okay, then she will have to use emergency contraceptive. Right, so this is if she misses the pill in the first week. Second, what if she misses more than or equal to 2 pills, right, in the last week? अब फिर से मेरी बात समझोगे. लास्ट वीक का मतलब क्या है? लास्ट वीक इज द वीक बिफोर द हार्मोन फ्री पीरियड. राइट, सो लास्ट वीक इज द वीक बिफोर द hormone free period. Right? Now understand, what is she going to do? She will finish the week, the hormone week. She will finish the hormone active week. जितनी भी बचे हैं उस गोलियां में, ठीक है, लेट्स से 3 बची हैं, तो वो फिनिश करेगी. राइट, एंड शी विल स्किप the placebo week. Okay, so मान लो इस 3rd वीक में उसकी 3 टैबलेट्स बची थी और वो 1 भूल गई, तो ये 3 वो खाएगी, ठीक है, और उसके बाद जो प्लेसिबो वीक आना था वो स्किप कर देगी. इसका मतलब क्या करेगी? 3 इस वीक के खाएगी एंड व्हाट विल शी डू? टेल मी. एंड अ न्यू पैक इज स्टार्टेड द नेक्स्ट डे. Is this understandable? समझ में आ गया कि नहीं? मुझे ये बताओ. Right? So she will skip the placebo week and immediately she will start a new pack. Is this clear? Okay? Yes, is it clear to everyone? Now, in case she hasn't skipped the placebo week, right? मान लो उसने 2 से ज्यादा पिल मिस कर दिया, right, and she has she is not skipping the placebo week. फिर क्या करोगे? If she is not skipping the placebo week, the concepts remain the same. जब तक कि next pack के 7 continuous pills वो ना खा ले, she will have to use a backup method. Is it clear? Right? So with this method जो मैंने अभी आपको लिखवाया, where she skips the placebo week, right, and a new pack is started, there is no need for her to use a backup method. But if she is not skipping the placebo week, then she will have to use a backup method of contraception unless 7 pills have been taken from the new pack. Yes, is it clear? So please, all of you tell me if it is clear to you or not. Okay? So I'll write it down and then I will ask you. Okay, else use backup method until she has taken 7 tabs from new pack. Yes, Archana, exactly. अगर उसने प्लासेबो स्किप कर दिया है एंड शी इज स्टार्टिंग अ न्यू पैक, तो उस मंथ में विड्रॉल ब्लीडिंग नहीं होगा. बट इफ शी इज वेरी पर्टिकुलर ऑफ हैविंग द विड्रॉल ब्लीड, तो वो क्या करेगी? शी विल फिनिश द पैक, which means she will finish the placebo also, then she will start a new pack. But इस time पे she will have to use a backup method, right? Okay, I will draw and try and explain once again. Let us say this is the last week before hormone free pills, right? And then she has these 7 placebo pills, right? Let's say, and let's presume यहाँ पे 3 tabs बची थी. Okay, so this is what is happening, right? So let's say in the last week before the hormone free period, her 3 tabs are left, but she has missed taking 2. Okay, so let's say she has missed taking 2. Now what will she do? So first option is, right, so first option is she will consume all these 3. So she will finish these 3. Then what will she do? Immediately after this, she omits the placebo pills. She is not going to take the placebo pills. But instead of the placebo pills, she will start a new pack. Yes, is it clear? So instead of the placebo pills, she will start a new pack. और इसमें उसको backup method का जरूरत नहीं है, right? She will not require a backup method because she will take continuous 7 pills. Is this clear? This part is clear? Vishakha, if she has missed 1 pill, right? तो अगले दिन क्या होगा? उसने 2 खाएगी. Yes, she will eat 2 na beta. So let's say what day is today? Is it Friday today? For example, it is Friday today. She forgot to take the Friday wala pill. On Saturday, what will she do? She will take the Saturday wala pill also and Friday wala pill also, right? So she will take 2 pills on one day, right? She will take 2 pills on one day and the rest she will continue. Is it clear, Vishakha? Yes, it will take the same time. It will take the same time. With more than 2 pills, it may turn out to be shorter cycle, but with 1 pill, it will turn out to be the same time. Okay? Right. Now, coming to this, is this part clear? Yes, 3 pills left are taken on 3 days. Yes. So, जब भी उसको याद आएगा, उस दिन वो एक खा लेगी, फिर अगली खा लेगी, फिर अगली खा लेगी. Right? Suppose she remembers it today कि अरे मैंने पिछले 2 दिन से नहीं खाई और आज याद आ गया. So what does she do? She takes 1 today, then she takes another one, then she takes another one on 3 consecutive days. Right? Then what does she do? She will omit the placebo wala week and she goes on to a new pack. Is this clear? Is this clear? Yes? Now look at this. Suppose she is taking no. Priyank, she is not going to take 3 in one day. She has to take the pills in the usual manner. Okay, she will not eat 3 in one day. She has to take them in the usual manner, beta. Okay? Yes. Okay. Now, the other option, as I said, is suppose this is the week before hormone free period. And let's say she is left with 4 pills here. And these are her placebo pills. Yes, these are her placebo pills. The other method is, now let's presume she has missed 2 or more. What will she do? She will take these 4, 1, 2, 3, 4, not together, one each day. Okay, she will take it in the usual way. Okay, it has to be taken at the usual time. Right? What does she do then? She also takes the placebo pills. Right? And then she starts the new pack. Now, in this second method, she has to use a backup method. She has to use backup until what? Until she takes 7 pills from this new pack. Do you get it? Do you understand it now? Right? So वो ये 4 खाएगी, फिर वो प्लासेबो खाएगी, फिर प्लासेबो के बाद वो फिर से नया पैक शुरू करेगी. जब तक उस नए पैक में से 7 pills नहीं खत्म हो जाते, she has to continue using a backup method of contraception. Is this clear now? Yes? Is it clear to everyone? So only once you've understood this is what is from your Leon-Spiroff. As I said, I always do the textbook part first, and then I will go on to a little variation here and there. Yes? Okay? Now, coming on to a little variation which is given by AOGD. Okay? So, AOGD के हिसाब से, right, वो कहते हैं, if your patient misses 1 to 2 pills, okay, so if she missed 1 to 2 pills, then they say take 2 pills at scheduled time, right? And there is no risk of pregnancy. So which means जब भी उसको याद आए वो पिल खा ले, ठीक? Right? So take 2 pills at the scheduled time. Okay, this is up to 2 pills. There is international guidelines say only 1, and at and beyond 2 their guidelines changed. For AOGD they are taking it up to 2 pills, right? Up to 2 pills जब भी पेशेंट को याद आता है तो वो 2 पिल उसी वक्त खा ले, right? मान लो उसको आज याद आता है कि उसने पिछले 2 दिन नहीं खाई. So what will she do today? She will eat 2 pills today. Yes? Then she will use 2 pills today. Right? हाँ, दलजीत वो तो बैकअप मेथड कितनी देर के लिए आएगा, इट विल डिपेंड ऑन उसका कितना बचा था उसमें. Right? But all this duration she will have to use a backup method. Okay? Then, the next thing AOGD says, if she misses 3 or more in first or second week, right? So if she misses 3 or more tablets in the first week or in the second week, तो वो क्या कहते हैं? Then they say, take 1 pill ASAP and continue the rest as scheduled. Okay? This is the first thing. Second, she should also use backup method for 7 days. She should also use backup method for 7 days. And third, she should use EC if there is history of unprotected intercourse. So, the guidelines are almost similar. मगर फर्क क्या है? जो international guidelines कहते हैं for 1 pill कि 1 pill तक मिस्ड इज ओके बट 2 and beyond you do this. AOGD ये कहता है from 3 and beyond. So that is the only difference. Everything else is the same actually. Is this clear to everyone? Yes. So this is if miss 3 or 4 pills, 3 or more pills in the first or second week. अब आता है what if she misses 3 or more in the third week? Right? So what if she misses 3 or more pills in the third week? अब क्या कहते हैं वो? Take 1 pill ASAP. वही जो हमने बोला जब भी याद आया, take 1 pill ASAP and finish the pack as scheduled. Right? So इसमें वो प्लासेबो भी लेने को कह रहे हैं. So finish the pack. Right? Of hormonally active pills. Throw away 7 non-hormonal pills. That's what I taught you, right? So discard the non-hormonal pills, right? So finish the pack, which is the hormonally active pack, right? Throw away the 7 non-hormonal pills, right? Start a new pack immediately, right? Start a new pack immediately. Use backup method for 7 days. Right? And if there is unprotected intercourse, she should take emergency contraception. Right? So, then she should take emergency contraception. Basically, the difference is only with 2 pill and 3 pills. So, with AOGD, they are talking about 3 pills, whereas with international guidelines, they talk about 2 pills, right? The difference is that with the throwing away thing, the number of days for which she will need backup methods is less. If she takes the placebo also, then the number of days for which she will have to use backup method will be very, very long. Do you understand the difference? Yes? So as Archana has calculated, I didn't do the calculations, but yes, suppose if she is taking the placebo pills also, then the number of days for which she has to use a backup method is very, very long, right? So ideally we say you throw away the non-hormonal pills, start a new pack, use a backup method for at least 7 days. Basic idea is कि hormonally active pills कम से कम 7 दिन continuously होनी चाहिए to cause a feedback inhibition. Yes, is it clear? Is it clear to everyone? Right? Do you want me to repeat any of this part? Then I can. Yes, of course. लिखा तो है, if there is unprotected intercourse, then she has to use emergency contraception. Okay? So if during this time she is having an unprotected ideally she should be using a backup method. Backup method, the easiest way is barrier contraception, a condom. Right? So the backup methods most of the times are condoms. Okay? And if there is an unprotected intercourse, then she should be using a emergency contraceptive. Is this clear to everyone? Yes? Is it clear, bacha? It is the same, amigo. In the first, see, if you are missing it in the first week or the second week, the protocol is the same. First week सबसे ज़्यादा critical होता है, ठीक है, और उसको शुरू करने में देर नहीं होनी चाहिए, right? In 24/4 regime, all same except for the days of backup. Yes, exactly. वो कम हो जाते हैं because placebo ही कम days है ना? उसमें सिर्फ 4 days placebo है. Nikunj, that is because you are starting on the day 1 of the menstrual cycle. When अभी dominant follicle और कुछ select ही नहीं हुआ है, right? This you are saying when you are somewhere in the middle and you don't know up to what time the follicle has already grown. Yes? So when you say day 1, you're talking day 1 of the menstrual cycle, where as of now, no dominant follicle has been selected. There will be no follicular growth itself. Forget about ovulation. Yes? But when you start at any other time, Nikunj, a dominant follicle may have been formed. Do you understand that? Yes? Sana, it has a failure rate, but then that is what is there. Okay, you can't be using an IUD as a backup method. Okay, she will not go and put an intrauterine device as a backup method. All right, is this part clear? Anyone wants me to repeat it, or you're okay with it? Yes? Okay, so now let's move further. What about extra pill? So no problem. If she takes one extra pill, there is no problem at all. She has to just continue the cycle. Okay. So if somebody takes an extra pill by mistake, there is no problem. She has to simply continue the cycle. She may finish the cycle earlier. Okay. She may finish the cycle earlier. Priyank, that is the problem. Pills ke liye, the patient has to be somewhat educated to understand. So it's very difficult, to otherwise explain. And that is why a lot of times women are non-compliant. And that is why the typical use failure rate is much higher than the perfect use. Perfect use is 0.3, whereas typical use reaches 7%. है ना? तो इसीलिए इतना ज़्यादा गैप भी है, because she needs to quite understand how she has to take it. Okay? Because you are breaking the cycle, no Nikunj? Right? So if you are breaking the cycle, then there is a possibility that the follicular maturation or ovulation might happen. Okay? So there should be no discontinuation in the inhibition. Alright? Nikunj, he's asking if the patient is an OCP, we know that no ovulation has occurred by backup in the 3rd week. See, किसी भी चीज का 100% success rate नहीं है ना? So although OCPs are going to inhibit ovulation, but you can't take a chance, right? If by chance there is an ovulatory cycle, or if there is ovulation, then the patient might conceive. Okay, so it has to be a continuous thing to help in suppression. Okay. Now, what about return of menses? What about return of menses? So as I said, when you talk about return of menses, majority of times it is going to happen within 30 days. Okay. So majority of times it is within 30 days after stopping the pill. Right? Sana, she will not know. You have to tell her all this. Okay? So she will come to you, or she will ask you what does she do, and you have to counsel her on what has to be done if she misses the pills. Okay? And that is why asking them to strictly follow the schedule is important. Okay? Now, so please remember, within 30 days there is a return of menses and return of fertility. Okay, return of fertility for all women, okay, usually happens up to 90 days. So most women will have return of fertility in the first month itself, right? And all women, अगर आप सबको consider करते हो, then all women will, return of fertility will happen definitely by 90 days. So it may go up to 90 days. Okay. Then somebody had asked me about duration of use. कब तक दे सकते हैं? So as I said, hormonal contraceptions can be given right up to menopause. Okay. They can be continued up to menopause. Can they be given to adolescents? Yes, they can be given to adolescents as well. In fact, are very commonly used in the adolescents as well. right? Is it clear? And as I said, when I say it can be continued up to menopause, this is when I talk about healthy non-smoking women, which means you have ruled out, from the medical history, the high risk factors and the history of smoking. Okay. Now, certain things that we should know as far as common side effects are concerned, right? The patient may ask you these. So you have to know about these common side effects, okay? So as I said, there are certain early side effects which actually improve. जिसमें आ रहा था nausea, okay, breast tenderness, headache, right? So these are early side effects and they improve as patient keeps taking the pills. The second important thing is unscheduled bleeding. So this is something someone was asking, I think Mr. Obzengani was asking me. So unscheduled bleeding. Now let's understand this. The first thing that you have to understand is that the bleeding that you see in between, if the woman is taking OCPs, is a breakthrough bleeding. देखो end में जो bleeding हो रही है वो तो withdrawal है. Do you understand that? So the bleeding that the woman is having in the placebo time is a withdrawal bleeding. मगर बीच बीच में भी उसको spotting हो सकती है, which is called as unscheduled bleeding, right? Now this bleeding that she is having in between is not withdrawal, it is a breakthrough bleeding. Now what do you understand by breakthrough? Now this unscheduled bleeding is typically seen when the estrogen component is less than or equal to 20 micrograms. Yes? Now why? Because you all should know that estrogen causes proliferation, right? When the estrogen content is less, there is less support in the endometrium. As I said, it undergoes atrophy, and atrophic endometrium tends to break down. Right? So this bleeding is because of atrophy or thinning of the endometrium. Right? So this unscheduled bleeding is actually more with low dose or very low dose pills. Yes, Mr. Obzengani, I remember you had asked this doubt. Is it cleared now? Right? So please remember, ये जो intermittent bleeding है, ये ज़्यादा तब होगी जब estrogen का डोज बहुत कम होता है, because this leads to atrophy or thinning of the endometrium, and then this thin endometrium breaks from certain points and those points bleed, right? So if a lady has a lot of unscheduled bleeding and she's troubled by it, आप क्या करोगे? Can you tell me what will you do? You will have to increase the estrogen dose. Yes, do you understand? So that there is some proliferation and those breaks are sealed. So when there is proliferation, those breaks are sealed. Yes, is this clear? Okay. Third, again based on the same concept that these pills cause thinning of the endometrium, if a woman keeps taking it month after month after month, they can eventually cause amenorrhea, which means if I ask you in which regimes will you see amenorrhea? So amenorrhea will be seen in continuous and extended regimes. Yes, so this is a side effect that you would see in women taking continuous regimes or extended regimes. Okay. Please remember hypertension. So yes, combined oral contraceptive pills or COCs or combined oral contraceptives, they will cause mild increase in blood pressure. Okay, they will cause mild increase in blood pressure, but please remember, overt hypertension is unusual. So ऐसा नहीं है कि इस दवाई को खाते ही किसी का BP suddenly 150/100 हो जाएगा. No. Right? There are mild elevations from her baseline, but it doesn't really cause overt hypertension. Is it clear to everybody? Venous thromboembolism. So this is something that I have told you before as well. There is a 3 to 5 fold increase in the risk, right? So there is a 3 to 5 fold increase in the risk, and as I have told you, this risk is going to be more with third generation progesterones. So if you compare within OCPs, a pill which has third generation progesterone will have a slightly higher risk as compared to a pill having a second generation or a fourth generation progesterone. Alright? So, as I said, risk is higher with third generation progesterones. Okay? Do they impact the carbohydrate and lipid metabolism? Yes. So if I actually go to the core effect, then OCPs negatively impact carbohydrate as well as lipid metabolism. Right? So they are shown to increase the insulin levels, they decrease the HDL levels, they can increase triglyceride levels, right? But please remember, whatever their impact on carbohydrate and lipid metabolism is, this is clinically not significant. So this is only bookish. That yes, if you go to the textbooks, it will have a negative impact on the lipid profile and on the carbohydrate metab. But this is clinically not significant. So they will, not cause any clinical changes as far as the patient's profile is concerned. Is it clear? Right. If they ask you about cancer risk, I have already told you, and that is what you are supposed to say. Only as far as breast cancer and cervical cancer are concerned, you are supposed to say there is no or slightly increased risk. Okay, so there is no or slightly increased risk which is temporary. Okay, so which is temporary and is associated only with current use, not past use. Right? Whenever we say current use, there will be some risk in those with the recent use only. Once she stops and she doesn't take it for 5 years, the risk is nullified. Okay, the risk is nullified. You tell me it is a progesterone breakthrough bleeding, right? There is thinning of the endometrium. Estrogen breakthrough कब होता है? जो PCOS में होता है. When there is proliferation which is too much, and proliferation outgrows the vascular supply. So PCOS में जो bleeding हो रही थी, वो estrogen breakthrough bleeding थी. यहाँ पे जो bleeding हो रही है मिस्टर ऑब्जन गाइनी, वो प्रोजेस्टेरॉन breakthrough bleeding है, क्योंकि प्रोजेस्टेरॉन की वजह से एट्रोफी हो गया एकदम, और एट्रोफी होने के कारण से एंडोमेट्रियम में ब्रेक्स आ गए. Just like, if I give you a typical example, when the skin becomes very thin, yes, you've seen that cracks develop. Right? The same is the concept with endometrium. If it becomes very thin, cracks will develop and there's going to be small bleeding from those cracks. Right? So this is progesterone breakthrough, not estrogen breakthrough. Is it clear? Purnima, that is because of the net effect on the cholesterol. So that is because of the effect on cholesterol. So net effect, if you talk about on the cholesterol of estrogen alone, अगर आप estrogen की बात करते हो, तो net effect होता है total cholesterol decreases, right? HDL increases, right? So that is why we say that in the initial years it will not increase the cardiovascular risk, right? But with advancing age, with comorbidities, the risk will outweigh the benefits. ठीक है? Okay, that is because of the net effect on cholesterol. जबकि जो आप रिस्क बोलते हो वो उसके थ्रोम्बोसिस की वजह से है, which is because of the coronary artery part, right? Because estrogens are going to cause thrombosis as well, or they are procoagulants. So there are two different things. One is effect only on cholesterol, and that is why you say cardioprotective in the initial years. But then over a period of time and with age, you talk about the thrombosis risk. Is that clear, Purnima? Yes? Okay. So this is things that you should know when it comes to combined oral contraceptive pills. Now, as I said, combined oral contraceptive pills have estrogen and they have progesterone. The same concept is with other methods as well. So can you tell me where else can you use estrogen and progesterone? So it could be a transdermal patch and it could be a vaginal ring, right? So things would be pretty much the same when we talk about now the transdermal patch and the vaginal ring. But if you want, what we will do is, yes, obviously, because you want to make the endometrium grow. PG Gynae. भाई मैंने बोला कारण है progesterone breakthrough because the endometrium is very thin. तो उसका इलाज क्या होगा मुझे बताओ PG Gynae. अगर एंडोमेट्रियम थिन है और उसमें ब्रेक्स हो रहे हैं तो आप वो कैसे ट्रीट करोगे? ईस्ट्रोजन दोगे और ईस्ट्रोजन क्या करेगा? प्रोलिफरेशन, जिससे कि वो ब्रेक्स सील हो जाएंगे. इज इट क्लियर PG Gynae? यस. सो इलाज क्या है? उस थिनिंग को थोड़ा थिक कर दो. डू यू गेट इट? ओके. सो PG Gynae मुझे सोच के बताएगी कि उसका डाउट क्लियर हुआ कि नहीं हुआ. वी विल टेक अ शॉर्ट ब्रेक एंड देन वी विल गो ऑन टू transdermal patch and vaginal ring, and then I would also talk in short about the emergency contraceptives as well, and in short about the postpartum contraception as well. Right. So we will still be talking about combined contraceptives, that is E plus P, and the another method is going to be a transdermal patch. Right? Okay. So these are also methods of E and P. Now when you talk about transdermal patch, the one that is available and that you have to know is ethinyl estradiol, right, with N. What is N here? N is norelgestromin. Okay, right? So norelgestromin. Okay, that's the progesterone that you see. It's a derivative of again third generation progesterones, right? Now ये जो patch होता है, it is composed of actually 3 layers. ठीक है, इसमें there is an outer layer which is water resistant, right? जो middle layer होता है, that is what is going to have the drug, right? So we will say that this is the one which is medicated and it is also adhesive, right? So it is medicated and it is adhesive. And then there is an inner layer. The inner layer is actually clear, release. So उसको निकालते हैं और उसे चिपकाते हैं. So it's a clear release liner. That's what we say it is, right? So a clear release liner which is removed and then the patch is stuck. Okay. Now, what is the release rate or what is the amount of estrogen and progesterone present in this? So, this has around a release rate of 35 micrograms of ethinyl estradiol and 150 micrograms of norelgestromin. Now, what I want you to know here is that although this has 35 micrograms of EE, please remember that through this patch, the total estrogen exposure, okay, the total EE exposure to the patient is actually 60% higher than OCPs. So ये आपको important है, ये पता होना चाहिए, which is why the risk of thromboembolism is more with the patch as compared to the OCP. So the total estrogen exposure of the patient through the patch is this, right? Now this patch has a surface area of around 14 centimeters square, right? So that's the surface area of the patch. Now there is another patch which is available which has ethenyl estradiol along with levonorgestrel, right? Now this has 30 micrograms of ethenyl estradiol and 120 micrograms of LNG, right? It has a surface area of around 28 centimeters square, and the inner two layers, so isme aur usme farak kya? This is actually a 5-layer patch. So the first one was a 3-layer patch, this is a 5-layer patch. But again, the same concept, that the inner two layers are the ones which are medicated. Okay, so the innermost layers are the ones which have the active ingredients. Okay, or they are the ones which are medicated. Now please remember, as I said, especially with the first patch, which is EEN patch, because the total estrogen exposure is more, there is a higher risk of venous thromboembolism as compared to OCPs. With EE-LNG, the risk is similar. Okay, so with EE-LNG, the risk is similar. Now please remember, since they are also estrogen and progesterone compounds, their absolute contraindications are same as OCPs. So their category 4 WHO is going to be the same that we have written for OCPs, right? अगर आपने ध्यान दिया हो, मैंने आपको कुछ देर पहले बताया था that risk of venous thromboembolism, if I ask you on what factors is it dependent, can you tell me one important factor on which the risk of thromboembolism is dependent? Anyone? Let's see who can come up with the answer. So one of the important risk factors for venous thromboembolism is BMI. Yes, so please remember, because the patch has a higher risk of venous thromboembolism, especially for the patch, the absolute contraindications are same as OCP, but I'm adding one special contraindication, which is BMI more than or equal to 30 kgs per meter square, right? So this is an additional contraindication for the patch. This was not there for OCPs. We haven't written BMI as a special contraindication for OCPs. But BMI more than 30 is definitely a contraindication for the patch. Is this clear to everybody? Why would someone use a patch over OCP? Can you tell me, if everything is almost similar, what do you think is the advantage of the patch over OCP? So, you know, as far as its failure rates are concerned, so it is as effective as OCP, right? So as effective as OCP, right? It is reversible just like OCP. It is non-coital dependent just like OCP, right? But what is the advantage? The advantage is she does not have to take the patch daily, right? So this is all similar to the OCP, but what is special here is that the patch has to be applied weekly. Okay, whereas when you talk about the pill has to be taken daily. Something that you people pointed out कि मैम ये patient को ये सब कैसे समझाना होता है या कैसे वो याद रखती है. So that is the problem with the pill. So to overcome that daily problem of the pill and forgetting the pill, the things like patch and ring have come up. So patch is applied weekly. Okay, just like OCPs, their perfect use failure rate is 0.3, which is less than 1%. All right. Just like OCPs, their side effects will also be the same. So here also your patient can have irregular bleeding, right? Which is what we talked about in OCPs as well. Patient can have weight gain, right? But just like OCPs, this is not a significant side effect. Okay, it's not a significant side effect. Then just like OCPs, it will also cause initial side effects like nausea, like headache, like breast tenderness, right? But these side effects will improve. Okay, so these will improve, right? No, Purnima, I think you are wrong there, beta. It has an estrogen. So whatever effect estrogen has on clotting factors, the patch will also have the same effects. It's basically releasing the hormones into systemic circulation. It's a slower release. That's the only difference, right? So it is still releasing estrogen into the patient's circulation, and all the effects are going to be what you know of estrogen. And because the total estrogen exposure is more, Purnima, that is why the risk of thromboembolism is also more. Okay? Right. Application. Right. So where is the patient going to apply the patch? Now the patch can be applied on the buttock, abdomen, as well as upper torso. Right. But please remember, not on the breast. Right. Because if she applies the patch on the breast, there will be a lot of breast tenderness. Right. So she can apply it on the chest, but not on the breast tissue, right? So buttocks, abdomen, upper torso, also on the upper outer arm, right? So upper outer arm can be done. Now the most important thing that you have to tell the patient is that a different site is used each time for the pack, right? So a different site. So for example, in the first week, if she is applied it on the arm, the second week she can apply it on the abdomen, right? So the site has to be changed. New patch has to be applied. So very important again, every week she's not going to repeat the patch. So new patch is applied every week. And she's going to do this for how long? For a span of 3 weeks. Okay, so she's going to do this for a span of 3 weeks. And then 1 week is going to be patch free, when she will have the withdrawal bleeding, right? So 3 weeks she will consecutively change the patch, and in the 4th week it is going to be a patch free week where she is going to have the withdrawal bleeding. Okay. Purnima, वहाँ पे doses बहुत अलग होते हैं बेटा, right? So when you talk about HRT, the dose is very different. When you talk about patch as a contraceptive method, the dose is very different. All right. Okay. Also, when we talk about HRT, you know, the formulations are also different a lot of times, right? So we will talk about that, but it's primarily because of the dose beta, right? Okay. Now, what if, you know, a patch gets detached? That is something which the patients are going to come up to you. So if a patch becomes detached, okay, either partially or completely, and it is detached for less than 24 hours, right? So if it's detached for less than 24 hours, what will she do? She will actually reapply the same patch at the same location, right? So reapply the same patch at same location. This is what is preferred, but they also say that if she wants, she can put a new patch also immediately. मान लो वो नहीं चिपक रहा, then she can use a new patch as well, and immediately. Okay. So ऐसा नहीं है कि अगर उसको नया patch use करना है, she has to wait. She can actually put a new patch immediately. But if it is detached for more than 24 hours, okay, if it is detached for more than 24 hours, so then definitely she has to use a new patch. So then a new patch is applied, okay, and then this day, जब उसने ये नया patch लगाया है, this becomes the day for subsequent changes. For example, earlier, let's say she was putting the patch every Monday. Now the patch gets detached and it remains detached for more than 24 hours. Let's say on Wednesday she gets to know that it has been detached. So on Wednesday now she'll put a new patch, and this patch, you know, now she will change the patch every Wednesday instead of Monday. Yes, so new patch is applied and this day becomes the new patch change day. And as I have told you previously, since it was detached for more than 24 hours, although she is putting a new patch, she needs to use backup method for contraception for 7 days. So she's going to put a new patch but also use a backup method of contraception for 7 days. Is it clear to everyone? Okay. Is there any delay in the return of fertility? So again, no, this is an E plus P compound and there is no delay in the return of fertility. So it is just like OCP. Remember, E plus P, इसीलिए मैं सारे एक साथ ले रही हूँ because a lot of things are actually same. So once you understand those things for OCPs, you would know them for the patch as well and you will know them for the vaginal ring as well. Right? So these are things that you should know for the patch. Now we move on to vaginal ring. Okay? Right. So vaginal ring, again there are different, and etonogestrel, we call it as ENG. ENG stands for etonogestrel. Etonogestrel is a 3-keto derivative of what? Desogestrel. Okay, so it is a 3-keto derivative of desogestrel. Right? And there is another ring which is a SAEE ring. Okay, the SA is, here the progesterone is segesterone. So segesterone acetate along with ethinyl estradiol. Right? Now, when you talk about the NuvaRing ring, here the release rate for ethinyl estradiol is 15 micrograms per day. And the release rate for ENG is 120 micrograms per day. Okay, so that is for the NuvaRing. When it comes to segesterone acetate, here the release rate is for segesterone, it is around 150 micrograms per day. And again, it has ethinyl estradiol. So the release rate is almost similar, it is 13 micrograms per day. Norelgestromin, the one we talked about earlier in the patch. So norelgestromin is again a derivative of 3rd generation progesterones. Okay, these are all derivatives. Okay. Now, so here the release rate for ethinyl estradiol is almost similar. Now, once we know this, something about the dimensions of the ring, although I really don't feel that they're going to ask you dimensions, but yes, you know, the NuvaRing ring is around 54 millimeters in diameter. Okay, so it is around 54 millimeters in diameter, whereas segesterone is 56 millimeters in diameter. How is the woman supposed to use the ring? So, whether it is NuvaRing ring or it is the SA ring, the ring has to stay in the vagina for 3 weeks. Right? So the ring has to stay in vagina for 3 weeks and then 1 week is ring free. Right? So 1 week is ring free. Now, इसमें क्या ध्यान देना है? What is she going to do after this is different for NuvaRing ring and SA ring. For example, if your patient is using the NuvaRing ring, she has to replace a new ring, which means the older ring has to be discarded. Whereas if your patient is using the SA ring, the SA ring is reusable. So that is the basic difference between the NuvaRing ring and the SA ring, right? So the same ring can be used for 13 cycles. right? So it can be used for almost 3 months or 13 cycles, and after 13 cycles she is going to change the ring, right? So that is the main difference that you should know is between the SA ring and the NUVA ring. Is it clear? Now please remember, again, just like the patch and OCP comparison, the main advantage of the ring is that it can be used over a span of 3 weeks, right? So that is the main advantage. Used for 3 weeks consecutively, whereas pill ka kya tha? Pill was something that she has to do daily, right? So this is the advantage. Now everything, whether we talk about contraindications or we talk about side effects, they remain similar to OCPs because they are again E plus P compound. So this is similar to OCPs. Is it clear to everyone? Yes? But please remember, some of you think that it is a vaginal ring and therefore, systemic side effects will not happen, and that is not true. So although it is a vaginal ring, the drug is being absorbed into the circulation. So you will see systemic side effects also with the ring. Is it clear? So ऐसे मत सोचना कि systemic side effects नहीं होंगे. जो side effects हमने OCP के पढ़े हैं, वो side effect यहाँ पे भी होते हैं. But yes, since it's not an oral thing, the nausea is less. So with the rings, please remember just that the nausea and breast tenderness is less. All right? Yes, is it clear to everyone? So basically, these are reusable, while the NUVA ring is non-reusable. Okay? 13 cycles. So 13 cycle का मतलब है कि एक month में जो वो use कर रहा है वो एक cycle है. So then she will replace the same thing. So I think I said 3 months. No, it will be 13 months. So over a period of time you can use it. I think that's what created the confusion. So 13 cycles hai beta. ठीक है? And 1 month is taken as 1 cycle. So she use it for 1 month, which जिसमें से 3 weeks it is inside, 1 week it is outside, and this is considered as 1 cycle. Okay? So she can use it over a period of 13 cycles. It can be washed, dried, kept and reused. All right? Now, will it cause some local side effects? Yes. Just like the pill causes nausea, this will also cause some local side effects like vaginitis. So it can cause vaginitis, it can cause leukorrhea. Right? So these things are seen. Can it cause unscheduled bleeding? Yes. So as I said, those things are similar for OCP and vaginal ring and for the patch. So it can also cause unscheduled bleeding. Okay? Rare side effects. मगर अगर मैं rare बोल रही हूँ तो वो rare ही है, सबसे पहले नहीं बोलना है. So rare is toxic shock syndrome. Now please remember that this is only and only seen with NUVA ring. So whatever case reports are there, they are of toxic shock syndrome, they are with the NUVA ring, not with SA ring. Okay? Another important question which the patient might ask and your examiners might ask, will she remove the ring at the time of contraception? At the time of coitus? The answer is no. The ring is supposed to stay in the vagina at the time of coitus also. It is not to be removed. Okay? Remember, the ring is self-administered. So a doctor does not need to put the ring for her. The woman can self-administer the ring. Okay? How do you do that? The sides of the rings are compressed and then it is put in the vagina. Right? So sides of the ring are compressed and this is simply put in the vagina as high as possible. Okay? So sides are compressed or pressed together, that's what we can say. Right? So the sides are pressed together and then inserted into the vagina. As high as possible. Right? So that is for the ring. Now, what if the ring falls out? So patient could say that, doctor, the ring fell out. Then what to do? So it can be reinserted, right? So if the ring falls out, it can be reinserted, but then again, certain guidelines are to be followed, right? Now, if the ring is removed or falls out, whatever, for less than 3 hours, right? So she recognizes it in less than 3 hours, then she puts it back and no additional method is required. Okay? No backup method is required. Which means the safe period for the ring is 3 hours, right? What about more than 3 hours? So if it is more than 3 hours, then again, it depends on whether it is in the first 2 weeks or whether it is in the third week. So if it is in the first 2 weeks, right? So if it is removed for more than 3 hours in the first 2 weeks, then she puts it back and uses a backup method. Okay? But if it is happening in the last week, then what she can do is, she can leave it out for 7 days and then insert a new ring. Right? So she can leave it out for 7 days, which will cause a withdrawal bleeding, and then she can insert a new ring. Yes, is it clear? Please remember the safe period, as I said, is 3 hours. That is for the NUVA ring. Okay? So safe period is 3 hours for NUVA ring, whereas for SA ring it is actually 2 hours. So same guidelines for SA, but the time span will be 2 hours instead of 3 hours, right? Okay. So this is what you should know about the ring, but as I said, remember the contraindications, the side effects, everything remains the same as for OCPs. What about risk of venous thromboembolism? It is not more than OCPs. That was true only for the patch. Okay? Not true for the ring. Is it clear to everybody? Right? So these were the E plus P methods that you should know, and with this we are done with E plus P, and I would move on to emergency contraception. Okay? So when you talk about emergency contraception, it is again some basic things that we should know about it, right? Now please remember this emergency contraception kya hote hain? They are the products that prevent pregnancy, okay, after an episode of unprotected intercourse, right? So they protect pregnancy after unprotected intercourse. Rajni, I didn't understand. Their mechanism of action is that they will delay the ovulation. So basically they disrupt the timing of ovulation. Right? And this is the main mechanism of action, but they also inhibit fertilization. Okay, they also inhibit fertilization, right? Now please remember, as far as the hormonal methods are concerned, there may be other ways how they act as well, but this is the primary mechanism, right? Please remember these methods, especially I'm going to name them, like ulipristal acetate, right? As well as LNG. I'm sure you know that they are the hormonal ECs that are used. Both of them do not inhibit implantation. Right? So they do not inhibit implantation. They are basically going to inhibit fertilization and ovulation. That's where they act. But when it comes to copper T, yes, so copper T is also an emergency contraceptive. We talked about it in the last class. This will inhibit fertilization as well as implantation. Yes, so this inhibits both fertilization and inhibits implantation. The most important thing what I'm trying to put across here is that once implantation has happened, emergency contraceptives cannot do anything. So they are not abortifacients. Right? So they can only protect jab tak implantation nahi hua hai. Once that has happened, they cannot really prevent the pregnancy. Yes, is it clear? Right. Now, when we talk about most effective, yes, Rajni, that's absolutely right. For POPs also it is 3 hours. Okay, right. Which is the most effective emergency contraceptive? So please remember the most effective EC is copper T. Right? And I think you will all remember ye kab tak use kar sakte hain? Up to 120 hours. Right? So up to 120 hours of unprotected intercourse. Right? What is the best thing about the copper T or advantage? That it can provide ongoing contraception. Right? So मतलब एक बार हमने EC की तरह use किया है, but the patient can keep using it as an ongoing method of contraception as well. Right? Whereas when you talk about hormonal, so if we talk about most effective hormonal EC, वो कौन सा है? It is ulipristal acetate. Right? So ulipristal acetate, which is what drug? It is a selective progesterone receptor modulator. Yes? So it is a selective progesterone receptor modulator. Right? What is the dose as EC? It is 30 milligrams and it is single dose. Right? So 30 milligrams single dose, effective up to again 120 hours. So or 5 days. So ulipristal acetate also effective up to 120 hours. Now if you ask, I'm saying most effective, so what is the pregnancy rate? So if you look at pregnancy rate with ulipristal acetate, it is around 1.2 to 1.8%. If you talk about levonorgestrel tablet, what is the dose of LNG tab used as EC? 1.5 milligrams. Now again listen to me very carefully. The total dose is 1.5 milligrams. This can be taken as a single dose or it can be taken as 2 divided doses 12 hours apart. Right? Or it can be taken as 2 divided doses 12 hours apart. Right? What is the pregnancy rate with this? So it is more with LNG tab. It is around 1.7 to 2.6%. So more effective is ulipristal. But what is important is कि ulipristal के लिए ना prescription चाहिए होता है, whereas LNG tab is available as over the counter drug. ठीक है? Do you understand? And that is why when we ask most commonly used emergency contraceptive, then it is actually a LNG tab. Right? So this is in general the most commonly used emergency contraceptive. It is over the counter drug. Right? You don't need a prescription for it. Then any other method that you know for emergency contraception? So another method is mifepristone. Right? Now there are no guidelines on specificity of the dose. They usually give it as a range. So some textbooks say 10 to 25 milligrams and some say 10 to 50 milligrams. So there is no consensus there. And basically in the US, it is not FDA approved as EC. So mifepristone is more being used as an emergency contraceptive in the Asian subcontinent, right? So in America, this is not approved as an emergency contraceptive, right? So dose is variable between 10 to 25 to 10 to 50 milligrams, right? Please remember, mifepristone is more effective than LNG tab, right? It is more effective than LNG tab, less effective than ulipristal. So that is for mifepristone. अच्छा, मैं एक चीज बताना भूल गई. What about LNG tab? ये कब तक यूज कर सकते हैं? What about LNG tab? Used up till what time? So please remember, the recommendation is LNG tab should be ideally used up to 72 hours of unprotected intercourse, right? So for LNG tab, it is up to 72 hours of unprotected intercourse. Mifepristone के लिए up to 120 hours of unprotected intercourse. So for ulipristal and mifepristone, it is 120 hours. For copper T, it is 120 hours. For LNG tab, what is on the pack or on the labeling is that it is approved for up to 72 hours, but there is definitely efficacy up to 120 hours as well. Okay. Now, another method that you should know is USP regime, although we are not using it, but yes, this is an older method, which is E plus P method, right? So, it is high dose estrogen. So what we do here is 100 micrograms of ethinyl estradiol and 0.5 milligrams of LNG, right? So 100 micrograms of ethinyl estradiol, 0.5 milligrams of LNG, and this is to be repeated at 12 hours. So basically the total dose will become 200 micrograms of ethinyl estradiol and 1 milligram of LNG. So much higher dose as compared to only progesterone compounds, and therefore the patient compliance is poor. So we are no longer using the USP method because of the poor patient compliance. Okay. Is there any contraindication for EC? So practically there are no contraindications except one, which is pregnancy. Yes. So there is only one contraindication, which is pregnancy. Okay. What would be the common side effects after these drugs? So if we talk about common side effects, it is headache, nausea, abdominal pain. Some women may also complain of dizziness, right? So these are common after the drug. One of the important question is, what if the patient vomits it out? Tab kya karna hai? So please remember this. If she vomits within 1 hour, then repeat the medicine. But if it is more than 1 hour, then you don't need to repeat the medication, right? Please remember, when a patient is taking the emergency contraceptive, let's say she's taken ulipristal acetate, can she now also simultaneously start OCPs? The answer is no. Okay, so you should wait for a period of 5 days before she is put on OCPs for continued, contraception, right? So, अगर किसी ने ulipristal खाया है, she should avoid the OCPs for 5 days. The reason is कि उसमें जो progesterone होता है वो UPA को एक्ट नहीं करने देता. So it will reduce the efficacy of ulipristal acetate. आप समझ रहे हो मैं क्या कह रही हूँ? So patient might ask you, doctor, अभी तो I am taking this as EC. Can I also simultaneously start OCPs? So you have to tell her no, wait for 5 days, right? So if she wants to really start OCPs, she should wait for 5 days and then start taking OCPs. The reason I said is that the progesterone in the OC pills interferes with the action of ulipristal acetate. Okay. Another common question that a patient could ask is there a menstrual delay with these tablets? The answer is no. Okay. So please remember, there is no menstrual delay with ulipristal and LNG. So menses should come on time. If the menses are not coming within 3 weeks, then you should test her for pregnancy. Is this clear? Right? So these are the things that you should know about emergency contraceptives, or which methods are available as emergency contraceptives. Yes, is it clear? Do you want to ask something? As many times. So Sanai is asking me, how many times can she take LNG in a cycle? As many times. ECs can be taken as many times, but you have to teach your patient that this is not a form of contraception, this is emergency contraception. She should use it like an emergency contraception and not make a habit of using the LNG tabs. So for ongoing contraception, you should counsel her with some other method. But otherwise, these can be taken as many times. There is no upper limit कि 2 बार खा सकते हो या 3 बार खा सकते हो. Okay? But you have to counsel your patient not to make it a habit. Right? Okay. Now, as I said, I will summarize a few things that you could be asked as far as postpartum contraception is concerned. And as I said, the guidelines vary quite a lot between different places. Okay, which means US has their own guidelines, which is given by ACOG. WHO has their own guidelines, and India to pata nahi kisko follow karta hai. So I'll try and summarize things for you as far as postpartum contraception is concerned. Right? Now the first important thing that you should know about postpartum contraception is that if a woman is breastfeeding, when should you start contraception? And if she is not breastfeeding, then when should you start contraception? No, Centroman Purnima is not approved as an EC. Okay, it is not approved as a EC. Right? So we should not be speaking about Centroman when we talk about ACs. All right? Okay. So please remember, if a woman is breastfeeding, you must start contraception counseling or start contraception at 3 months. Whereas if she is not breastfeeding, you should start contraception at 3 weeks. Okay, so ovulation will actually return without breastfeeding at 3 weeks, and ovulation will return even with breastfeeding at around 3 months. So that is the time when she should use some form of contraception. Okay. Now what about OCPs? Let's see what you know about it. So if your examiner asks you, when should OCPs be used in breastfeeding postpartum women and in non-breastfeeding postpartum women, what would be your answer? So this should be more like Viva question. So tell me, what would be your answer if your examiner asks, when can you start OCP in breastfeeding women and when can you start OCP in non-breastfeeding? Anybody with the answers? Let me see who can give me the correct answer. Chalo, jaldi jaldi batao. This has to come from your side. Tell me. Okay. So I didn't get the answer, so I have to speak out the answers, which mean. So in breastfeeding, you give it at 6 months, not earlier than 6 months. Okay. In non-breastfeeding, you can start at 3 weeks, which is given by WHO, and 4 weeks is what is given by ACOG as well as AOGD. Right? So in non-breastfeeding women, you can start OCPs at 3 weeks. This is a WHO recommendation, whereas ACOG and AOGD say 4 weeks. ठीक है? So पहले 2 हफ्ते में बिल्कुल नहीं करना. Can you tell me the reason why? नो ब्रेस्ट फीडिंग में ओसीपी यूज नहीं करते बेटा. सो 6 months. No, don't make these mistakes. It is not recommended between 6 weeks to 6 months. Okay? Not recommended. So it should ideally be taken after 6 months. Okay? 6 weeks पे सिर्फ कब करना है रजनी? सिर्फ तब करना है रजनी एंड पूनम if there is no other method available. Right? Then in breastfeeding you can start at 6 weeks. Not ideally. Ideally in breastfeeding it has to be 6 months beta. Is this clear? Yes, is it clear to everyone? So don't make these mistakes. That is why I thought I would summarize it, the postpartum things separately so that there is no confusion. Take? Okay. Then IUDs. What about IUD? So please remember what I told you. There is a post-placental IUD which I did teach you. So this is if it is put within 10 minutes of placental expulsion. Yes. What is postpartum IUD? Yes. So Priyank is giving me the right explanation. First 2 weeks में there is a very high risk of thromboembolism. So even if the patient is not breastfeeding, do not give OCPs in the first 2 weeks. Start it at the 3rd week. Okay. Postpartum is within 48 hours. Right? अगर 48 hours पे नहीं हुआ तब कब करना है? So what if the woman comes to you beyond 48 hours then? So if not put within 48 hours, then put at 4 weeks. Okay? So then put at 4 weeks. You can put intrauterine device at 4 weeks, which becomes interval IUD, right? It becomes interval IUD. So postpartum is within 48 hours, post-placental is within 10 minutes. If it is not put in the 48 hours, then you can put an intrauterine device at 4 weeks. Is it clear to everyone? Okay. What about female sterilization? What about female sterilization? Okay, I think PG Gynae is asking me a question, but her question is not clear. Beta, why not to be given? किसके लिए पूछ रहे हो और कौन से duration में पूछ रहे हो? Are you asking for OCPs, PG Gynae? Can you please write down? Okay, what about female sterilization? So I'm giving you only Indian guidelines for female sterilization because that's what we need. It can be done within 7 days postpartum. If not done in 7 days, तब कब करना है? Then at 6 weeks. So if you have not done the postpartum sterilization in the first 7 days, then you will do it at 6 weeks. At that time it will be called as interval sterilization. It will no longer be called as postpartum sterilization. ठीक है? All right. Then we talk about progesterone only pills. Okay, progesterone only pills. Now, if your patient is non-breastfeeding and if your patient is breastfeeding, what is the difference? So, if your patient is non-breastfeeding, it can be started immediately, which is both WHO as well as ACOG guideline, right? You can start in non-breastfeeding women immediately, right? If she is breastfeeding, then ACOG says after 3 weeks, whereas WHO says after 6 weeks, right? And this is for breastfeeding women with who want to take progesterone only pills. Why can we give? What do you mean why can you give? For contraception, right? At 3 weeks, the risk of postpartum venous thromboembolism is nearly normalized. ठीक है? 3 weeks के beyond thromboembolism का risk उतना नहीं होता. It is back to normal. So therefore now you can start OCPs. Okay? Sana? Right? All right. What about DMPA and implants? So as far as DMPA and implants are concerned, they should be started at 6 weeks, not earlier than 6 weeks. The reason is again thromboembolism, right? So the reason is again thromboembolism. This is what is given on the implant and DMPA labeling, right? जो packet labeling होता है, packet labeling itself says you should use it at 6 weeks postpartum. Practically, just like POPs, they can be given earlier as well, right? Like 3 weeks. But on the labeling, it is very much 6 weeks. So for POPs, any kind of only progestational compounds, whether it is POP or it is DMPA or it is implant, it is 6 weeks. Yes? Is this clear? So this is as far as progestational compounds are cleared. So this is what you should know for postpartum contraceptive, when to start which one, right? Okay, if somebody asks you, when you talk about postpartum IUD, right, is the rate of expulsion higher? Let me see if you can recall, right? Can you tell me, is the risk of expulsion higher? The answer is yes. So if you are using postpartum IUDs, the expulsion rates are higher as compared to non-postpartum or interval IUD insertions. Okay. Sana is asking why to stop till 6 months, because OCPs interfere with breast milk secretion. Okay, बच्चे, Sana, उसका कारण कुछ और है. जो हम 6 months बोल रहे हैं, वो हम इसलिए बोल रहे हैं because OCPs are associated with what? They are associated with alteration of the breast milk, whereas progesterone only compounds do not affect the breast milk secretion. Okay, just give me 2 minutes, till then you can you can type your doubts. I have to make a phone call urgently. Any other doubts that you people have? Otherwise, this is it for today. So with this we cover, I think, the entire thing about contraception. Sir has covered male and female sterilization, and this covers the hormonal and IUD part of contraception. Okay, so if you have any doubts, let me know. Now, a couple of next classes will be taken by Dr. Anil, right? We will announce the date soon to all of you. And I would be taking, next topic we would be taking is COVID in pregnancy, because I think that is something that you all wanted us to cover in this course, right? So, Vishakha, we will talk about HRT because we are taking drugs separately, beta, right? So if you have seen the schedule, we will cover the gynae drugs separately. So when we are doing gynae drugs, we will definitely cover HRT, right? So we will be covering the OBS drugs and we will be covering the gynae drugs, and in gynae drugs, we will definitely cover HRT. All right? Okay. Emergency contraception can be taken any time, Priyank. Okay, emergency contraception can be taken any time because they are what? They are progestational compounds. We are not using E plus P compounds. So ECs can be taken any time. As I said, there is no contraindication to EC. The only contraindication to emergency contraception is pregnancy. Okay? Right. What is the day today? See, because of the pandemic and everything happening, we don't even know what day is it. Okay. So can we keep a class tomorrow? No problem. We will not keep it on Thursday. Okay. But can we keep it tomorrow? So we'll keep a class tomorrow. Is tomorrow okay for everyone? Tomorrow 5 p.m. Is everybody okay with that? Yes, quickly give me a head nod. Next class tomorrow 5 p.m. Are you okay with that? Do I have a head nod from everyone? No? Okay, Priyank मना कर रहा है. Priyank क्यों मना कर रहा है? See, the majority says tomorrow is okay, so we'll keep a class tomorrow, and We'll give you a break on Thursday because काफी सारे consecutive classes हो गए हैं. So tomorrow is Wednesday. Okay. We keep a class on Wednesday. Thursday we'll keep an off. Friday again we'll have a class. Okay. So tomorrow you have a class at 5 p.m. Thursday we will keep an off. And Friday again we will have a class at 5 p.m. Okay. Vishakha, देने को तो दे सकते हो, but it has a lot of side effects. It's difficult to tolerate such high doses, right? So most people are non-compliant, but USP can be used, right? So it can be used, but please remember it is less efficacious than all other methods, which means USP regime will have a higher failure rate as compared to LNG-tab, as compared to ulipristal, as compared to mifepristone, as compared to copper T. So among all emergency contraceptives, the highest failure rate is with USP regime. Also highest side effects. So it is not the preferred method. Okay? Right. So this is final. Take care everybody. Take care.